Good afternoon, everybody. Thank you so much for joining the Southwest Center for Human Relations Studies at the University of Oklahoma for our monthly webinar series. I'm Asia Mukes, Communications and Project Manager, and we are excited about the 2019-2020 season of our monthly webinar series. Our hope is that we continue the conference's tradition of working to improve racial and ethnic relations on college campuses by providing virtual learning opportunities. So this season is really going to be great. We have a lineup of scholars who will cover a wide range of issues, including immigration and DACA, institution reform and planning, and critical pedagogy. On October 30th, presenters from Mount San Antonio College will present Keeping the Dream Alive, a college-wide approach to embracing dreamers. The cost is $25 and registration is still open. This season, we've introduced a new student track that focuses on ideas that speak directly to the experiences of students and is either facilitated by or co-facilitated by a student. They're intended to identify emerging scholars and connect students in the NCORE community to each other. Our student track webinars are always available at no cost. They're open to anyone, and they're held the first Wednesday of every month. Make sure you're live posting. I did a hashtag search today and saw that people are actually posting pictures from their office and lunch and learns and auditoriums. So we want to know where you're watching. Tweet, Instagram, and Facebook pictures from your office using the hashtag NCORE and the hashtag Start the Conversation Online. You may end up in a very special NCORE video. Today we have Brendan Crow, a third-year medical student at Georgetown University School of Medicine. Prior to medical school, he worked for 6 years in health informatics before realizing his passion for patient care and health equity. His research interests include the social determinants of health and the intersection of race and medicine. Today, Brendan will be discussing how race is currently used in medical education. The center is grateful for Brendan's expertise. So I'm going to turn it over to Brendan. He is going to go through his entire presentation and we're going to take questions at the end. I encourage you, if you have any questions, please use the Q&A box. That's a way for us to keep track of how the questions come in. So thank you, Brendan. I'm going to turn it over to you.
Great. Thanks a lot, Asia. So as she mentioned, my name is Brendan Crow, and I'm a third-year medical student at Georgetown University. And I want to talk with you today about race, racism, health, and biology, and how they are interconnected and talked about in a convoluted way in medical education. And I'm going to summarize some of the history and the ways that race is used in clinical medicine, as well as talk about some of the research that we've done at Georgetown and what we want medical schools to do to improve the way that race is used in medical education. I want to start with a story. The story comes from Dr. Richard Garcia, who was a pediatric emergency physician. And I've heard this a couple times in medical education from students who have written on this topic. And it was written a little while ago now, but he tells the story of a childhood friend of his named Leela. Leela was Black and she suffered from multiple respiratory infections. And when she would arrive to the emergency department or to a pediatrician, the physicians would often use the phrase, 2-year-old Black female with fever and cough, or 4-year-old Black girl with another pneumonia. Leela is Black. However, her underlying condition, what contributed to these trips to the emergency department, was never diagnosed or recognized until a radiologist who had never seen Leela face to face saw her x-ray on the wall and asked, "Who's the kid with cystic fibrosis?" So some of you who aren't familiar with medicine may not know this, but cystic fibrosis is commonly thought of as a white disease. a disease that affects the white population. There are many associations that are made in medical education or talked about casually that imply one disease affects one racial group. You might have heard sickle cell disease that affects Black people. These are shortcuts that are made, and they appear throughout medical education. I'm going to talk about a few of them. So that was just one example where race is used in medical diagnosis that sort of explains a little bit of an implicit bias that physicians have, which ignored the symptoms that the patient was presenting with. So I want to give a brief outline of how I plan to talk about this topic. I'm going to give some historical context and how race has been used in science and in medicine, but also other areas. I want to talk about how race is used in medicine today, how it's used in medical education, how it's used in clinical education. I want to talk a little bit about our research that we did at Georgetown, and then wrap it up with the implications and advocate for the changes that we want to see in medical education. So some historical context, brief overview. I would love to include a whole hour on this topic, but I'll just describe where racial classifications have started, starting in the 1700s with Carl Linnaeus. This was a physician who was well known for classifying plants and animals into species that helped us better understand all living things. And he classified 4 subspecies of Homo sapiens. If we jump ahead to the mid-1800s, Samuel Morton was an American physician. He took this a step further. Let's keep in mind the context. This is the United States in the 1800s, early 1800s. And he proposed that the human species was actually 4 different species. And he supported this with evidence that he said separated races based on the circumference of their head, with the white race as the largest head circumference and the Black race as the smallest head circumference. You can see how this might have fit the political and social hierarchy at the time. In the 1900s, an American anthropologist took steps to undo some of the work that had been built on over the decades from Carl Linnaeus and Samuel Morton. And that was to state that race was a social construct and not a biological construct. In 1950, UNESCO made statements to try to roll back some of that momentum that had carried many scientists, physicians into believing that racial groups had underlying biological differences that separated them. And there's some controversy following that, because many scientific studies and academic institutions would go back and forth about whether there was a biological underpinning of race. I include this Tuskegee experiment in 1972. It lasted for several decades before that, but I include it because even though this came after Franz Boas, it came after the UNESCO statements, the Tuskegee experiment was designed based on the belief that the Black race experienced a disease, syphilis, different than other races. That justified the experimentation on Black men, but it affected many people at the time. And then I also want to mention the Human Genome Project in 2000 that showed that there was, it supported that there was no way to break racial groups up based on genetics. And further studies have shown that there is more genetic variation within a race than between races. A little bit of political context here. We can imagine in 1860s when there were 3 racial categories, white, black, and mulatto. And then over the decades, the number of racial groups has increased. It's expanded now, if we look at 2010 census, to include various definitions, social definitions of race. You'll see ethnic groups, racial groups as they have been defined, as well as geographic and national definitions of race. So this is another example of political definitions of race and how they have changed over time. So if we looked at the laws in Virginia, you can see that in 1700s, 1800s, 1900s, the definition of race changed over time. And practically speaking, most people couldn't and can't prove that their ancestry would be for one specific race. And as one historian, James Horton, wrote, one could cross a state line and literally and legally change their race. So I say all this, including the historical context, political context, to explain that race is an invalid scientific variable because it is not a discrete value or category, because it does change over time based on political motivations, scientific motivations that defined race differently over the years. And then I want to also bring this quote up, since I'm talking about the role that governments and politics play in defining race. Dorothy Roberts writes that race is a political system that will not be brought down with scientific evidence alone. Race persists neither because it is scientifically valid, nor because its invalidity remains to be proven. Race persists because it continues to be politically useful. So now I'm going to talk about the way race is used in medicine. In 2019, you wouldn't expect that race would be used as an inherent biological or fixed category. And I was hopeful that when entering medical school, that race would be taught in a different way. Race as a concept and racial categories were not defined in medical education. And my understanding of race as a fluid and changing concept stands in opposition to the scientific nature of our Western medicine with evidence-based facts and empiric realities. So we asked, why is it that these old notions of race have held on in medicine? We found, and both in medical school and now in clinical rotations, that race is still often treated as sort of a biologic, innate, or genetic characteristic that everyone has. It's specific to a race. And yet medicine and race remain intertwined, and race-based medicine is still being taught and practiced everywhere in the United States. So many clinical decisions still include race as a factor, and I'm going to give you a few examples that we've been taught in medical school of where race is used in medicine. So the first example is the ASCVD risk calculator. ASCVD stands for atherosclerotic cardiovascular disease. And so this is measuring the risk that someone will have a narrowing artery leading to a blocked artery. And I want to emphasize that this is a real calculator that is used frequently, often included in physicians' notes and compared and carried forward for subsequent visits to the doctor. It's a popular tool, and as you can see on the right side, it takes race into account, in addition to considering patients' age, sex, and blood pressure. And you see the categories that are available: white, African American, and other. I think it's important to point out, as you'll see in these other examples, which races are chosen in our calculations. And in this case, if you chose other, it states that this tool may overestimate or underestimate the 10-year risk of having a cardiovascular event, and specifically mentions that some Asian Americans and Hispanics may be underestimated. The reason for this wasn't made clear on the website, and when I was asking the professor who was teaching this, he wasn't sure. He hypothesized that most data has been done on the biological differences between white and Black people. And he assumed due to the US's history of slavery and focus on doing these studies. I think that is I think there is accuracy in that statement in the sense that the US has focused on the white and Black difference. I think what was interesting is he understood it as biological differences between white and Black population. And this is where I think there is room for better conversations with students in the classroom and in the clinical setting. And then the other thing I thought about when it comes to data justifying differences between white and Black, I think we should actually be asking what contributes to those differences that we are seeing in the data. And if we don't yet know what the factors are, obviously more research could be done, and I think more research is being done, but we should be including that in our education. We should also be including it right here within these tools to explain that it's not biological differences, and thus furthering that belief that there are biological differences between races. So I'm going to come back to this algorithm in a bit. We'll just share another example. This comes from GFR calculation, or glomerular filtration rate. And it's a test of kidney function, or how well our kidneys filter our blood. So when calculating GFR, whether or not a patient is African American is taken into consideration. The scientific basis for this was never explained in our lectures, but more taught to us as a fact. When looking this up later on the National Kidney Foundation's website, their explanation was that African Americans have higher muscle mass. There was no discussion on how someone would define themselves as African American. Is it how the patient identifies, or is it how they appear Black to the physician? I think, and this tool is also, this calculation is used in many clinical settings. It's also baked into the electronic medical record that calculates GFR. And I think with the inclusion of technology in medical practice, the race factor is now being baked into our algorithms, so that it's even thought of less now because it's already part of the automatic calculation that the computer generates. So I think the other important point is that when thinking about and discussing this, use of this is not this calculation, it's not just an academic exercise, because the number actually affects the type of treatment that a patient would receive. So it has real world implications, and we need to be thinking about what the actual implications are of separating one race, African Americans, from all other races. Another example, this was brought up on a rotation. We had a lecture that talked about tools to use when when an infant presents to the clinic or the hospital with a fever, and the UTI being a possible cause. So this calculator comes from the University of Pittsburgh. It's one of the main ones used, and it takes into account whether the infant is Black, fully or partially, you can see there in the middle, into account in the probability calculation. So if you fill in yes to every question except the last one, then the probability of UTI is around 11%. But if you change the race question from yes to no, the probability doubles to 25%. And when this was presented, nobody asked or was, asked about the explanation of why this is. And I'm going to come back to it later in the presentation because we looked into the evidence behind this. So let me give you one more example of the way race is used, and that's in hypertension or high blood pressure guidelines. These guidelines have been known as JNC8, or the Joint National Committee, who comes up with guidelines every few years to help physicians make decisions on what treatments to give patients with high blood pressure. And they collect lots of information from big studies and then distill down those guidelines to help make it easier for physicians to digest all that information. And one of the two of the paragraphs in this, I'm going to share one of them here, summarized the risks for different groups. So we read this here: for an adult 45 years of age without hypertension, without high blood pressure, the 40-year risk of developing hypertension is 93% for African Americans, 92%, 86%, 84%. And you might read it and not think twice because it's just simply a statistic. But when you think about what they're comparing here, it's like comparing apples to oranges. We've got African American, we've got Hispanic, whites, Chinese adults. We have nationalities, racial groups, ethnic groups. And I think as a physician's thought process or a patient's thought process, how do I identify? What if I identify as more than one group? What if these don't, fit my identity? What is the risk to me? So I think it makes it difficult to assess and apply to patients. Give another example in the second paragraph. It says hypertension is a greater contributor to events in women and African Americans compared with whites. I find this problematic because it establishes whites as the baseline or the norm to which all other racial and ethnic groups are compared to. So I think this is an example where we're contributing to the white-centric view of the world and the white-centric way of treating patients by establishing that whites are the normal and other ethnicities or racial groups are not. Okay, moving on. All of what I just talked about is one of the spheres in which race is brought up in a medical context. And that is the sphere where race itself is considered as a risk factor for certain diseases and illnesses. The other area where race is discussed in medical school and in medicine is in conversations around implicit bias, cultural competence, and social determinants of health. So that's what I'm going to touch on next. And these topics you may have seen in the news. They're also big topics in medical education, and I want to give definitions of them now. So implicit bias, the first one, the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. And I'm giving definitions because I'm going to use these in a minute. The next one is cultural competence, the ability of providers and organizations to effectively deliver healthcare services that meet social, cultural, and linguistic needs of patients. And lastly, social determinants of health, defined as the conditions and the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. This can include poverty, education, and racism. So these topics, they're all worthy goals to be striving for, and I think we should be incorporating them and perhaps even expanding the use of them. But when we combine it with the first sphere in which race is brought up, where race is used as this risk factor, we're finding that medical students are simultaneously learning to treat patients on the basis of race for GFR, kidney function, or high blood pressure, or UTI, but also not treat patients on the basis of race, according to our sort of implicit bias and cultural competence training. And we're starting to be thinking about race and the multidimensional and its social meaning. But I think we have a long ways to go. So we have some race-based medicine, but not too much race-based medicine. Is it's okay and actually encouraged to make medical decisions based on race, because medicine treats race as a biological feature, a risk factor, but also don't be racist and treat patients differently based on race. So how does this make sense? So I want to talk through the framework that we've come up with that helps explain how we got into this convoluted way of thinking about race in medicine. So let's start with race. We know from the prior examples that I was just mentioning that race is often listed as a risk factor for certain diseases or illnesses. So logically, one's race must lead to and contribute to biological health and outcomes just on its own. So we connect these terms like this. Next, we also talk about implicit bias and how that can lead to treating people differently based on their race and perpetuate these health disparities just based on treatment. So let's add another arrow here and include implicit bias and cultural competence as a way to counter the way that racial categories leads to racism. And we also know that cultural competence and social determinants of health play a role in medicine. And let's include, show social determinants connecting racism to biology and health. Okay, and lastly, we have this second arrow here connecting biology and health to race, and the way that scientific studies contribute to the idea and the belief that there are biological differences between subjects of different races. So for example, a study might specifically look at rates of migraines in people coming to the ER, and they might intentionally differentiate the subjects based on race. And then we happen to see a statistical difference based on racial lines, or that falls along racial lines. We don't often see that reasoning behind that is interrogated. Instead, it contributes to the new fact or belief that there are inherent biological differences between races, rather than trying to figure out why those differences exist and why are they showing up in our data? Why are they present in our society? Okay, so that was a lot, but you can see sort of the circular reinforcement of these three interconnected pieces: race, racism, biology, and health. All right, so let's move on to focus just on these two. What's wrong with this relationship? One, race and racial categories are not defined for us as medical students. It's assumed that we know what they mean when they refer to race. And you could say that everyone knows what race is, but I think we often have different understandings of race based on what we're exposed to. So the UTI risk calculator that we saw earlier, that referenced the non-Black race, fully or partially. I'd want to know, what does that actually mean? Does it mean a patient who identifies themselves as not Black? Does it mean a patient is half Black or more? Are we supposed to follow one of the laws that we saw with Virginia in the past, such as that one drop rule? And this is not only an issue with the UTI risk calculator, but it's an issue across medicine, where racial categories are not defined, neither in our preclinical lectures, but also in studies. We don't read, when reviewing the studies, how racial categories defined. Were they defined by the physician doing the research? In one of the review articles that we looked at on spirometry, or how well lungs function, it found that only 17% of the studies defined how they had assigned individuals to racial categories. And 94% of them failed to include any other measures of social class that may better clarify the underlying differences in outcomes. So my colleagues and I find this kind of astounding that we aren't doing a better job of defining these differences and giving definitions, because it doesn't support the scientific nature that we're being taught when it comes to evidence-based medicine. The definitions are key. The next, so the next ones are issues with the data, and that happens when we start looking at the sources behind some of these calculations. So if we went back to the UTI calculation, this was done, this is based on a study in 2006 that looked at racial and ethnic differences in rates of urinary tract infections. And the objective of the study was to characterize the differences in racial and ethnic rates of UTIs. And right away, you can sort of see an issue with the study in that it was from the outset looking for differences between racial groups and establishing that arrow that runs from right to left in terms of biology and health to race, so reinforcing that idea. And this study was looking back at medical records of 465 patients over a year. And it found that when compared to the general population, African Americans had a lower rate of UTIs. So the conclusions led me to have more questions than were actually discussed and answered in the study. Because it's something unique to the ER, is it unique to the urban environment they were in? And given that it only looked at one ER in an urban environment, could you really extrapolate those results to other urban environments, to other cities? And it didn't go into how the racial groups were defined. So it makes it hard to justify using this risk calculator in other settings. And I think that's a weakness with lots of these calculators used in medicine. So the last thing I want to mention is the importance of historical context. And this, I think, is also very important in medical education. And one of the best examples of this is looking at the spirometer. So I want to give a brief history of this based on reading this book by Lundy Braun. Talked about the history of the spirometer. So these devices were used to measure lung function in terms of the volume that we inhale and exhale. And if you're using these machines, you're having to factor in the calculation age, height, and race. And both of these, one computer and one manual measure, include race in their calculation when you're coming to measure the volumes in patients. But it seems weird to use race in this way. We'll talk a little bit about the history of using that. Lundy Braun is a professor at Brown University, and she's done a lot of work in this area. So it starts with, I'm just giving a brief summary of it, but in 1785, when Thomas Jefferson wrote notes on the state of Virginia, he stated that there were differences in lung structure between white slave owners and enslaved peoples. And that this was really just a philosophical idea that he had. It wasn't supported by the measurements that came from spirometer once this was invented. So once it was invented, Samuel Cartwright, a plantation physician, he took that idea by Thomas Jefferson and put it into action and studied the lung differences between enslaved people and slave owners, and found there to be, on average, a 20% less lung volume in enslaved people compared to white slave owners. So 30 years later, a guy named Frederick Hoffman, who was a statistician for a life insurance company, and he used the measured data by well-known scientists at the time, because it wasn't just Samuel Cartwright. I mean, physicians after that continued to design studies to further this belief that there were biological differences based on race, ignoring the environmental and social contributions to those differences in lung function. And so 30 years later, a statistician at insurance company used those measured differences to make claims about, one, the lack of fitness for African Americans for freedom. And according to him, he said the smaller lung capacity of the colored race is in itself proof of an inferior physical organism. So these measurements were then used to justify higher premiums on life insurance. And several decades later, in 1922, some of the first lung function standards were created, and some of the research that came from that was incorporated into the reference handbooks for physicians, and it established that there were differences in lung capacity for white and Black people. And so these are starting to get baked into the clinical reasoning and belief that there are innate biological differences between racial groups. And I think this really illustrates the ways in which belief in racial differences equaling biological differences leads to the like the political, social, and economic justification for treating people differently based on race. Racial discrimination existed before the scientific studies came out trying to justify differences between races, biological differences between races. But now that you had these scientists producing evidence that claimed differences based on race, you can now more easily justify laws and treatment that would be different based on race. So we've got decades and decades of research and common assumptions that there are biological differences based on race. And you see it play out in this one example, playing out in justifying higher premiums just simply based on race. Okay. So the other thing that she wrote was that, she went on to say this quote here, but also that the exclusive racial framework continues in the 21st century, but rather than having a fluid, historically contingent system of classification, researchers treat race as a stable category, uncomplicated by social class, sex, or geography. And I feel like this statement is fairly obvious, but the ramifications of it are less so, and that's because not only do we get spirometry as a scaling factor for a Black population, but it's also the reason why so many of the tools that physicians use center on the Black-white difference. So it comes from understanding that our data is based on, the data that these tools are based on, whether it's the spirometer or the GFR, they're all rooted in the scientific studies of the past and the belief and understanding that there are biological differences based on race. So while supposedly supporting a biomedical understanding and somehow justified as neutral, it reinforces the social hierarchy that we have based on race. Okay. So we talked about historical context, we've talked about the use of race in medicine, and we've talked about the convoluted nature of the way race is used in decades and decades of research, and then reinforcing that, the studies reinforcing the belief that there are biological differences based on race. And now I want to talk about some of the research that my colleagues and I did at Georgetown. And I want to give you a little bit of background of what brought this up. We have lectures during the first year and a half to 2 years in which they summarize a lot of the basic medicine, physiology, pathology, and race is brought up in many of the lectures and often presented in the way that assumed a biological difference. So when we got to the end of first year, we felt like there must be a way to contribute to rolling back that idea and instead reinforcing and teaching students that race is a social construct and that it should be understood in terms of these environmental and social determinants of health, and hopefully also contribute to less implicit bias of future physicians if we're not teaching about race as biology. So we were inspired by a study by Jenny Tsai. She was then a medical student at Brown University, who analyzed a handful of lectures and the way that race was used. And we expanded on that to analyze all the lectures in our first year curriculum. Okay, so 3 other students and I analyzed every lecture from our first year, and that included over 17,000 PowerPoint slides. We had a detailed method in how we went through each of the slides, looking for the ways that race and racial and ethnic terms were used, and then documenting the context in which they are presented. And then categorize those references. Were they presented in a biological context and implying biological differences, or were they presented in a social or multifactorial context? And what we found was that most of the time, 75% of the time, it was presented in a biological context. And we have come up with a few things that we think we can do to prevent that possibility of contributing to implicit bias, and also think it plays a role in accurately addressing racial health disparities. So I'll show a little bit about our research here and how it came down, how we broke it down. So on the left, ways that it might be brought up as a biological risk factor or a genetic, specific genetic gene that would be found in this racial group versus another racial group, without providing the justification or broader context that would help us understand why a certain biological reference could be associated with one racial group. And then the other side, the social or multifactorial context, it would be, if we're presenting on health disparities in prostate cancer, it would explain that these are the socioeconomic factors, the availability of treatment, whether treatment was done equally to a population, that those contributed to our racial health disparities, as opposed to biological differences contributing to health disparities. The next level of categorization was breaking down the biological references to understanding different ways in which these are brought up. So we had 4 categories. The smallest we found was race correction. So that would be in, say, lung function or GFR kidney function tests. The largest category was epidemiology without context. So if we were like comparing high blood pressure rates in the US without providing the context of what may be contributing to high blood pressure differences between population, racial groups, if we don't explain that context, that the environmental context, the structural racism, the just access to care as explanation, then we're contributing to the idea that there are inherent biological differences within one racial group that it would explain the racial health disparities. Risk factor. I think this is an important one here because risk factor is often used as a proxy for something else. So if we're thinking about asthma, then is it a race that's the risk factor, or is it the environment that's the risk factor? Is it, and high blood pressure, is it race that's the risk factor, or is it discrimination that's the risk factor? Is it stress that's the risk factor? And I think we can't adequately address those health disparities if we're not understanding what the true cause is. And I think too often we stop short and we assume biological difference based on race rather than interrogating the data a little more and to say, and the context in which that data is collected, and to say what is the true risk factor contributing to health disparities. The last category was vignettes or patient cases. And this could be a little controversial in how it's used, but too often race is used in the one-line summary of a patient in the hospital or in a clinic. And by saying, like we used before, like 4-year-old Black girl with recurrent pneumonia, it's not race that needs to be highlighted in the one-sentence summary. I don't know that contributes to a better understanding of the disease or what another clinician should understand. Instead, we perhaps should be using these other or underlying risks that better summarize why this patient has recurrent pneumonia. And we don't put our blinders on and thinking about what is specific to one race. Instead, we're thinking about the true symptoms and signs that would indicate one diagnosis over another one. Okay. One of the aspects of our research, by accumulating all of the racial and ethnic references in our research, we calculated the frequency in which they were used. And we hypothesized in the beginning that more often Black or African American would be used compared to white. And that was the case. So we did a word cloud where the larger the font is, the more frequently it was presented. And I think this emphasizes the ways in which certain races are prioritized over others, but also certain races are pathologized over others. And it's often presented in a way that makes white or Caucasian the norm, and another race would be the abnormal, the comparison. Okay, so that was a little bit about our research. Where we hope to take this is in sort of redefining how we think about race in medical education and medicine, and the ways that we should restructure that three-legged triangle that I was using earlier. So instead of perpetuating these mistakes that we've made in the past in terms of assuming biological difference based on race, we need to go further than just having these social determinants of health, cultural competency, or implicit bias training, because that's really just sort of trying to cover up our underlying assumptions of biological differences. And we need to rethink that relationship. So here's where we should be. We need to recognize that we still live in a racialized society. And though, because of that, race-based medicine might have some intuitive sense, it seeps into our clinical reasoning and judgment, and into our clinical tools in a way that lets it go unquestioned, and certainly lets it go unquestioned in medical education to the degree that it should be. So we've created a framework that we think will better address this. So we think first, this is the old framework to reference. We think first that racism should be at the heart of the discussion. And we need to talk about and recognize the ways in which this is used to perpetuate the sort of exploitation of people of color, and the concept of race has been used to sort of create the system that we live in, based on racism. And I think with centuries of research and data, it sort of flipped the way that we think about race and racism. So the concept of race is be sort of embedded into our culture and our psyche, that we come to view it as sort of an unquestionable thing, and that race as itself is unassailable, that you can't even adjust the meaning of it. So it sort of comes from lack of understanding of our past, and we continue to sort of ignore where we come from. And one of the ways that I've come to understand is that it's not that we believe that we created the system, but we're still responsible for ending sort of this racialized thinking and racial injustice that's perpetuated by our decades, centuries of structural racism, of scientific racism. So there's no denying that racial health disparities exist, and in the race and medicine world, it's common to say that racism isn't the risk factor for poor health outcomes. Racism is the risk factor for poor health outcomes, and it's not race. The farthest I could find that quote was back in 91 by R.J. David. And we definitely agree with this. So we want to take this out and put racism at the center. And I think that still leaves room for understanding social determinants of health. In fact, we can put more emphasis on social determinants of health. And so we understand racism leading to these health disparities. We can also, instead of thinking about cultural competence, we can think about structural competence, because I think we need to have not the idea of achieving cultural competency, but always assuming that we have, or believing and pursuing cultural humility, that as we go into understanding cultural differences and the differences of racial groups. Okay, so I wanted to talk about better understanding racial health disparities, and I have these three examples that stand out to me. One, asthma, and I think there's already been a lot of work to sort of undo that, and that is that it's not asthma, or it's not racial groups that contribute to a higher rates of asthma, so much as the environments in which people live, and understanding why people are segregated into environments that have poor air quality, can help us better understand why certain racial groups have higher rates of asthma and lead to higher rates of death due to asthma. And I think there's a nuance to understanding the way that race is used in the way that asthma is understood too. I think there are implications of the health effects on a racial group being passed on through other ways. So whether it's being stressed or whether it's living in an environment that can show up as biological differences, but we need to understand the thing that's contributing to those differences is not race in itself. It's the environments and the discrimination, systemic discrimination, that's contributing to those high rates of asthma. Prostate cancer is another really interesting one. In the last decade or so, there have been more studies, randomized controlled trials, which are the highest level of evidence that we have, and through which best recommendations come from. And there was a commentary just this year that sort of summarized some of these randomized controlled trials and found that when controlling for access to care, equal treatment, there weren't differences in outcomes based on race. So white men and black men had equal outcomes when given equal treatment and controlling for the other factors. And it also, shows that we need to be addressing the real cause of those differences, things that have been contributing to it for decades, and that is the socioeconomic factors. All right, I'm gonna skip on to the next one here. This was a great quote that we found by Michael Omi and Howard Renant. There's a continuous temptation to think of race as an essence, as something fixed, concrete, and objective. There's also the opposite temptation to see it as a mere illusion, which an ideal social order would eliminate. In our view, it is crucial to break with these habits of thought. The effort must be made to understand race as an unstable and decentered complex of social meanings, constantly being transformed by political struggle. Again, these authors bring up the role of politics in defining race, and I think that's it was a revelation to me when reading these and thinking about race and how scientists over the decades use those political definitions, the definitions of their time, to define race, and that really starts to unravel our understanding of race as biology. Okay. summarize a little bit about why it's important. I've sprinkled it a little bit in there, but first thing being racialized diseases have real world outcomes. So it's not that race doesn't have a role to play. One professor, Joanna Full-Wiley, wrote, racialized bodies incur biological consequences. So it's not to say there's not a relationship between racism and health, but the way that we currently learn about it, the way that we are taught about it in medical school is the reverse. It's a bit backwards. So we need to start thinking about this in terms of the intergenerational trauma and the allostatic load, the stress that racial groups experience, which leads to the physical, hormonal, or genetic responses to these physical and emotional challenges. So if we think about these more in a social context, then we can understand where our interventions need to take place, rather than trying to come up with medication specific to a race, rather than coming up with a treatment protocol specific to a race, like in high blood pressure. So, and that leads to reframing how the issues, reframing the issue changes how we address it. Because if we stop recognizing it as biological differences, we can focus our attention and energy on the social, economic, political, historical causes of these health disparities. And lastly, I think it's also important for the implicit bias. There are often studies, there have been several studies. One that cited surveying medical students and their belief in inherent biological differences based on race. And I think one of the important ways to address those implicit biases that we have is to talk about race in medical school, and not just like in individual lectures where we have like one-off talk about race. It needs to be incorporated in all of the lectures anytime we're bringing up race, even if it's part of a calculator that has been supported by decades and decades of evidence. I think we need to be talking about race anytime that it's brought up as a risk factor, as a correction factor, as a as more aggressive disease in one race, because that's going to help. It's going to help me. It's going to help future physicians better address the underlying issues that are contributing to these health disparities. So we have a list of 8 things that we want medical schools to do. And the first on the list is incorporating courses on the history of race and racism in medicine. I think it's not enough to just talk about the history of race. It's not enough to just talk about the way that race has been used in scientific studies. I think we also need to have a reckoning within medicine and as an institution to share examples of explicit structural racism that has gone on for decades in the past. And there are examples today that we can use and to help further the conversation about it. The next one was, whenever bringing up race or ethnic groups, we should be using definitions. So if we're talking about health disparities, we're talking about differences in outcomes based on race, I think we need to define it in order to reinforce the accurate understanding of race for medical students, because I think a lot of medical students don't come in with a complete understanding of race. And even if they do, it would certainly help by having students talk with each other and students talking in class about the role race has in medicine and in science. We should remove it from our case, our vignettes, our one-liners, because that also can contribute to the idea that there must be inherent biological differences based on race. It doesn't have the same value that knowing someone's age has. We don't need to, it doesn't need to be the second, characteristic when describing a patient or person, for that matter. Fourth thing here on the list is that is regarding IRBs. These are institutional review boards. These are groups of people at research institutions that define what is appropriate to study when starting a new research project. And I think this gets to that, that old bidirectional way in which racial characteristics and statistical differences found between racial groups reinforce the idea of biological differences between race. So if we get changes incorporated into our review of future research studies, that can help disrupt that feedback of racial differences assumed to be some biological factor. I'll just give one quick example. A few weeks ago, I was on a neurosurgery rotation and presenting on a research study that was done just this year on brain tumors. And this study looked at a study of these tumors, specific tumor, and the frequency in which it presented in certain racial groups. And because there happened to be a longer lifespan for a Black population than the white population, the conclusion was made that there must be a protective factor inherent in a racial group, and assumed to be stated that there was an unknown genetic factor that contributed to this longer lifespan. The paper never talked about how they defined people based on racial groups, or whether it was the patient who defined themselves as Black or white. It also, interestingly, was overwhelmingly a white population studied. So the conclusion was sort of extrapolating that this small percentage, less than 20%, was representative of a protective factor inherent in a Black racial group. So I think it's not something that this existed 100 years ago, 50 years ago, 20 years ago. Lots of studies are coming out that are still finding statistical differences based on race and assuming that there must be an underlying genetic difference. Okay, it's probably a little fast for our captioner. So our last group of four here, what can medical schools do? So removing race as the risk factor and incorporating what is the underlying contribution to prevalence of the disease, the course of the disease, and stop using race as the proxy, because I think just simply as listing it as a risk factor inherent to a racial group perpetuates the idea that that's some sort of inherent biological difference. The next one, epidemiology statistics without context. I think this is an easy jump to make. If you assume that there is, you're being taught that there are statistical differences based on race without the context, that could sort of easily worked into our diagnostic reasoning that it just must be inherent to one racial group. Instead, we should be thinking about and talking about what are the factors that are really contributing to these differences based on racial groups. It's not to say that we shouldn't be using race in our studies. I think race has a very important role. It's just that there's an important limit in which, to which we use race, and it helps identify that there are disparities, but we need to be careful in terms of how far we take the statistical differences, and really take it a step further and interrogate what are the real causes of those differences. So physicians stop assuming patients' race and instead ask how they identify. I think we also should be asking, is race even needed to be documented? in the chart. If it does need to be documented in a medical record, perhaps it's best included in the social history or the social context in which they live, which may help better educate whoever's reading that medical record to understand the environment that they're living in, rather than making quick assumptions and judgments just simply based on race. And lastly, schools can do more to incorporate the structural competency and cultural humility in medical education. Just this year, Georgetown has incorporated lectures. We had them just a few months ago, led by the Office of Diversity and Inclusion. And I think it was a really great addition to our curriculum. And I hope that we can see that not just, one-off course, but affecting lectures throughout the curriculum. I want to mention a couple people. My colleague, Haley Rumenper, Dr. Sarah Qureshi, is our advisor, one of our deans of diversity and inclusion, our dean of diversity and inclusion, Dr. Susan Cheng, and Jennifer Tsai was one of inspirations for some of this research, and she has written a lot about it. And lastly, Mansi Shah. And thanks to NCORE and to Asia for having me.
Thank you, Brendan. Thank you so much. This was really fascinating. I have to do practice sessions with all of our presenters, and I was so excited to have this particular presentation. We have a couple of questions. Nikki Messmore, she says she works at Indiana University School of Medicine. She loves so much of what you're presenting. One thing to consider for reflection: the use of race and other identities in vignettes do serve a purpose to get medical students to consider how they will treat future patients, and understanding that their patients will hold different identities from their own. She says, consider the example of Rue from the Hunger Games, described with dark skin in the book, yet when a Black girl was cast, white fans were furious because they imagined her to be white. There is an issue of racelessness in which white people assume that all characters are white when they read about them. Now, there would be an issue if the vignettes were stereotypes, such as saying the HIV patient is a gay man, white or Black. But when used outside of stereotypes, it can help students better picture their future patients and thus better treat them. Does this make sense? You're muted.
Yeah, that is a great comment and contribution to that. And I think that it would help to talk about that when weighing when to use race in describing a patient. It's a great point.
I encourage for the rest of the participants, if you have any questions, this is now a great time. We had an anonymous attendee ask, our cases sometimes include race specifically to get at the social context. Is there a good way to do that, or is it better to exclude racial indicators from cases entirely?
Yeah, I guess, let's see, am I still muted?
No.
I mean, I think that's sort of related to the first comment. And maybe I didn't, and I don't think I said it clearly enough. When race is included, the vast majority of the time, or ethnic group is included, it is to trigger a stereotype or make an association with a disease. So we talked about in the first story I gave of cystic fibrosis. When a question is given to us and it says, 5-year-old Caucasian boy, the reason for that is to give us an indication of the prevalence and the, lead us towards the right answer choice. But by always using race or ethnic group with certain diseases, with certain stereotypes, it perpetuates that stereotype. It reinforces the stereotype, and it does sort of an injustice for medical education and for future physicians to start ingraining those stereotypes into our minds, when really we should be considering it, we don't need the racial group to help us think about it. What we need are to think about the signs and symptoms that a patient is presenting, and no matter what the race is. So perhaps a better way to include it, is if a question, instead of having race in there, or instead of having, like if you're going to include race, you'd include it in a different context. Let's say if you had an image of a person, whether black, white, or whatever racial group we choose, and that answer choice would not be based on their race, but instead be based on their signs and symptoms, the social context in which they live, that would lead us to the right answer choice. I don't know if I'm saying that correctly, but what I'm saying is, like, we don't want to reinforce their stereotype. We want to undo the stereotype to expand like what we could expect to see appear in any racial group.
So we have another question. The person says that they're curious as to how the research has been received by medical educators. Is there a lot of openness to the suggestions from your project so far?
Yeah, that's a good question. I think we have been wondering that throughout the project, and has been a very positive response. And at Georgetown, a positive response. We're going to, so the next steps of our project are to present our findings to the Committee on Medical Education just another month, and advocate for the changes that I've mentioned here. We're also going to do a survey of students and faculty. And one other addition to our research has been analyzing audio of all the lectures in our first year to help us better understand how people talk about race. The survey will help us better understand how people actually think about race, because our analysis of slides is simply stuff that's written down. So I think it'll help us fully understand the way race is used in medicine. We have these other pieces that contribute to our understanding and use of race in medicine.
So we have another question. My experience has been that Western doctors hardly consider any social factors affecting health, or using that knowledge on how to help heal, forget about race. If you're lucky, you get 10 minutes with your doctor. Do we really think doctors are supported in taking time to consider factors associated with race?
Yeah, that's a big question. Yeah, I mean, I'm worried about that too. I agree. There's so many pressures on doctors and all healthcare providers in general to sort of move through appointments quickly and make decisions quickly, and I think that contributes to poor decision making. We then rely on our stereotypes. We rely on our assumptions because we're pressured into making quick decisions, and fail to consider and ask about the underlying cause for whatever you're brought in for, whatever you're coming in for, or things that you're someone might be at risk for, because we don't have the time to ask about these environmental and social causes of conditions. So it's a great question, and it's a big it's a big issue.
So I have a question. My background is social work, and I spent much of my career in medical settings. And so I would be curious what you would say, what your pushback would be to physicians who would say that's not the role of the doctor, that is the role of the social worker. I'd just be curious if you've heard that. And if you did hear it, what would be your response?
Let me see if I understand that correctly. What would be that it's not the role of the doctor to think about race, or what was that?
Not necessarily to not think about race, but to think about the social context and then sort of deal with the social stuff.
Yeah, the things that come to mind would be that Western medicine has long focused on a biomedical model and has excluded social factors, has excluded even psychological factors, and focused on a very limited view of health. And so some might say that we should keep that focus, you know, it should not expand to other aspects of health. But I think that's I think that's an old view on medicine, and I think we do need to be fluent in understanding all of the things that contribute to health, because we're also looked to and to understand health in a way that isn't specific to just the clinical setting. It's not specific to just diagnosis. I think, especially some of the primary care specialties, you're expected, and when we should be involved in understanding all aspects of our patient's health, the community, the environment. And then, so I think that's one aspect of it. And I think the other thing is that there is a hierarchy within medicine that keeps the institution from moving to a flatter organization that would recognize equally the role of other specialists in achieving the health that we all want for patients. So there's a role for a physician, and there is a role for a social worker, and there is a role for psychiatrists, physicians too. And I think recognizing that equally would help, and know that sometimes the social worker is the captain of a person's health, because that's contributing more to their poor health than what the physician can do in terms of the diagnosis or in terms of an assessment. I think there's a need to raise that as the, at times, most important role, as the social worker being the most important role in achieving the health outcome that we all want for the same patient that we're caring for.
Okay. So we have a comment. It says, Brendan, thank you for presenting your work. As a Native American, I have to agree with your statements on cultural competency and humility being a part of medical education, especially with the high Native American population here in South Dakota. The medical students and current practicing physicians are going to have a Native American patient at some time in their career, and having some exposure to Native American culture is beneficial. Again, thank you. And we have a comment that says, thank you so much for sharing your work. Will you provide the PowerPoint to our participants?
Yes. So I understand that this is recorded, and there's also a way to get to our research and our PowerPoint on the website below. It also has contact information for us there.
All right, well, are there any final closing remarks, Brendan?
Thanks for the opportunity. I think it's an important topic that, you know, we need to talk about more broadly, not just within medical education. I think this is a role for lots of people to play in bringing up race in medicine, because it's something that's easy to try to ignore because it's a difficult topic. And race certainly has a complicated history. But I think the way to make progress on it is to talk about it. And thanks for the opportunity to talk about it here.
Okay, can you give everyone your email address so that in the event they want to contact you, they'll have it?
Yes. Best email address is crow.brendan@gmail.com. It's spelled CROW.BRENDAN@gmail.com.
All right. Well, thank you so much, Brendan. This was a fantastic presentation. And I just want to remind everybody that we have another webinar that is open for registration in October. The last Wednesday of every month is our sort of normal track. And again, it'll be talking about a college-wide approach to addressing dreamers. So thank you again, Brendan. And thank you, everybody. Have a great day.